male patient, aged 52, with a history of severe gingival recession in the roots of the right maxillary first molar. This patient was sent to my surgery, and I sent him for root canal treatment due to the sensitivity, and he had a radicectomy. Now, this X-ray shows us the result of the first attempt to keep this tooth functional and in the mouth. I'll go back a slide. And in this area we can see a lesion. Although the X-ray would indicate that it's in the palatal root, at the time of extraction we observed the following. See, here are the remains. This is the healed area of the alveolus, where the radicectomy was carried out. This area is the distal root. It was difficult to take these images, but the lesion was so deep that the alveolus of the distal root was joined to the apical lesion. We suspected that the lesion was infected, communicating with the maxillary sinus. We carried out very careful and precise tests. We assessed the lesion physically. Using instruments, we didn't really notice anything more than the hard wall of the lesion. We performed the test that we are all already familiar with, where the patient tries to exhale air with his nostrils pressed together, and the passage of air can be observed through the bubbles of blood when there is oroantral communication. In this case, there was none. As a precautionary measure, we used a collagen membrane in the wall we were focusing on, covering this area as close as possible to the maxillary sinus and the lesion. Sorry, this photo is out of focus. I'm always nervous with these cases, so the photo didn't come out great, but here we can see perfectly once again the cone that is right at the entrance of the lesion, and in due course we pack it, and a second cone allows us once again to fill the apical lesion and the area that corresponded to the alveolus at the distal root of this tooth. The post-extraction X-ray shows us the filling material in this site. Here is the collagen membrane, and here is the material. Why can we clearly observe the material in some cases and in others not, as in this case? I believe, I must admit, that I probably didn't adequately deal with the material and that it remains, let's say, slightly mixed with the clotted blood, not with any space, but mixing material and the clot as it's not fully packed. This is a clinical judgment, and it's probably the cause. Here we can perfectly observe in the area that there could have been a risk. This was the site. Obviously we can observe the size of the lesion and the alveolus, and this area is where apparently, I know from clinical tests, no communication occurred, because in addition to rinsing the alveolus with saline solution, it is obvious that if there had been a hole, the patient would have immediately had liquid escaping from his nostrils. All tests indicate that there was no marked perforation. We prepared for any handling while packing the material, etc., to avoid this infection and communication. And then we see the lesion and the material in this X-ray immediately after inserting the material. In this X-ray, I just made a slight mistake. This X-ray, which we saw and described, did not yet contain the material. Here, we see the graft material. This irregular area that you see is the material that we use as surgical dressing. We took the X-ray with the surgical dressing protecting the wound, but we can observe perfectly how far the material extends. Technically, the collagen membrane would be in this area. And here we have the initial post-extraction X-ray of a healing wound after 2 months. When cropping the X-ray, I just took this yesterday, perhaps it would be appropriate to observe what we had at the time of extraction and lesion debridement, and what we have approximately 11 months later. This area corresponds to the root alveolus, which is perfectly obvious here, at the time of extraction, and as we can be certain, with our X-ray image, that the objective of ensuring that this alveolar area repaired itself was met. There is also proof that there was no perforation in the maxillary sinus, even though we didn't see the material intact in this site. Why is this? I'd like to emphasize from a strictly clinical viewpoint that in this area the material is, as I said before, greater. The proportion between the clot and the material doesn't allow for X-ray observation of the results. But undoubtedly, I believe that the objective was indeed met. Here, we see this area as it was before,